Hello everyone, welcome to the fourth video of autonomic pharmacology. In this video, we are going to discuss in details about OPC poisoning. So what is OPC or organophosphorus compounds? In previous video, we have discussed that organophosphorus compound are irreversible inhibitor of acetylcholine esterase enzyme. We discussed it as a drug, but organophosphorus compounds are not clinically used as a drug. Rather, it is used as insecticide. Farmers in rural area uses it commonly. So the organophosphorus compound poisoning is mostly seen in rural areas and the affected persons are usually farmer. There may be suicidal or homicidal case. Suicidal is very common but homicidal is rare. OPC are very highly lipid soluble drug. As a result, if it falls on the skin of farmer, it is rapidly absorbed into the circulation. We know that our cell membrane is composed of lipid bilayer, so highly lipid soluble drug can easily cross the lipid bilayer, and by crossing the skin and the vessel wall, it easily enters into the circulation. It can also be absorbed through lungs, while the farmer sprays this as insecticide in the field. Now the mechanism of organophosphorus compound. This is our presynaptic membrane, this is our postsynaptic membrane, and acetylcholine is synthesized and stored in the presynaptic membrane. On proper stimulation, it is released into the synaptic cleft and stimulates the acetylcholine receptor on the postsynaptic membrane, thus stimulates the parasympathetic nervous system. After acetylcholine doing its job, it gets metabolized. The enzyme here which helps in metabolism is acetylcholine esterase enzyme, and organophosphorus compound mainly inhibits the acetylcholine esterase enzyme. So inhibition of acetylcholine esterase enzyme results in increased amount of acetylcholine in the synaptic cleft. So more acetylcholine will bind to acetylcholine receptor and there will be more stimulation of cholinergic or parasympathetic nervous system. This is the gross mechanism. Actually, what happens at molecular stage? This is our acetylcholine esterase enzyme. It contains a hydroxyl group. And this is our organophosphorus compound which contains a phosphorus molecule. We know that hydroxyl compound are negatively charged and phosphorus are positively charged. So organophosphorus compound and acetylcholine esterase forms a covalent bond. So there is formation of acetylcholine esterase and OPC. As a result, acetylcholine esterase gets permanent inhibition. So there is permanent stimulation of parasympathetic nervous system. So what will be the clinical features? We have said that organophosphorus compound actually increases the concentration of acetylcholine and stimulates the parasympathetic nervous system. At heart, it will cause bradycardia, and bradycardia will lead to decreased cardiac output. As a result, there will be hypotension. Parasympathetic nervous system also works in eye. In eye, it stimulates the pupil and causes miosis. This will be clinically present as pinpoint pupil. In gland, parasympathetic nervous system stimulates secretion. So there will be excessive sweating and salivation. In bronchus, parasympathetic nervous system causes bronchoconstriction, which leads to asthma. And due to increased secretion in the airway, there will be accumulation of liquid in the airway that leads to bronchial wheeze. In gastrointestinal tract, stimulation of parasympathetic nervous system leads to contraction of GIT smooth muscle, and that will clinically be present as diarrhea, involuntary defecation. Reverse peristalsis in esophagus will lead to vomiting, and due to increased hydrochloric acid secretion in the stomach, there will be hyperacidity, which will clinically present as heartburn. Stimulation of parasympathetic nervous system in the urinary bladder leads to contraction of the bladder, and that will clinically be present as urinary incontinence. All of these features are seen due to muscarinic receptor stimulation. Heart is inhibited due to M2 receptor stimulation. We previously discussed that. Eye due to M3 receptor stimulation. Gland due to M3 receptor stimulation. Bronchus due to M3 receptor stimulation. Gastrointestinal tract due to M1 and M3 receptor stimulation, and bladder due to M3 receptor stimulation. So what will be the effect on nicotinic receptor? Actually, the nicotinic symptoms are extremely rare, may occur in 5 out of 100 people. So when an M receptor are stimulated, there will be flaccid type of paralysis. We have discussed in previous video how an M receptor stimulation leads to flaccid paralysis, and that will clinically be present as muscle weakness. And stimulation of an N receptor will lead to tachycardia, hypertension, convulsion, and tremor. Actually, this is contraindicated. We have previously seen that there bradycardia is seen, but here we are saying that there will be tachycardia. Actually, we have also said that nicotinic symptoms are extremely rare. So tachycardia is rarely seen. It will be seen if the organophosphorus compounds concentration is very high. In our first video, we have discussed that acetylcholine is the neurotransmitter for preganglionic, sympathetic and parasympathetic nervous system. In parasympathetic nervous system, acetylcholine is also released from the postganglionic nerve fiber, and sympathetic nervous system there is adrenaline and noradrenaline. But acetylcholine is common in case of preganglionic nerve fiber. So large amount of acetylcholine or cholinergic drug will lead to stimulation of both sympathetic and parasympathetic nervous system. And if sympathetic nervous system is stimulated, there is stimulation of heart that will lead to tachycardia and hypertension, and stimulation of central nervous system that will lead to convulsion and tremor. Now we will discuss in details about the treatment of organophosphorus compound poisoning. When a patients come in emergency with life-threatening condition, what we do? We take some general management. At first, we do ABC resuscitation. Then, when the patient is a little stable, we take quick and short history. A patient of OPC poisoning will have the history of insecticide spraying or suicidal ingestion. Then we will examine the vital sign. In vital sign, we will find bradycardia, pinpoint pupil, sweating, salivation, asthma, involuntary defecation, urinary incontinence, etc. So after the history and examination of vital sign, we will confirm that it is a case of OPC poisoning. These 3 steps should be done in a very short time. Then we will remove the contaminated cloth from the person's body. As we have discussed earlier, organophosphorus compounds are very highly lipid soluble, so the poison which are present on the cloth can be absorbed from the cloth further. So removing of cloth and storing it for medical legal purpose is a must doing step in management of OPC poisoning. And then the skin should be washed with normal saline to clear out the unabsorbed organophosphorus compound from the skin. Then gastric lavage should be done by 2% potassium permanganate. And the last step in general management is catheterization. So why we need catheterization? Previously we discussed in short about atropine, that atropine blocks all muscarinic receptor. So when it blocks M3 receptor on the urinary bladder, there will be no micturition and urinary retention. So before giving atropine, we must do the catheterization so that after giving the atropine, there will no urinary retention. So after doing the general management, we will go to our pharmacological management. At first, we have to give atropine, which is an antidote of organophosphorus compound poisoning. The dose is 0.6 to 1.8 milligram. There should be no confusion between milligram and gram. It is milligram. And it is given in IV route, and the time for it is 10 to 25 minutes. Why it is not given quickly? Because if we give atropine quickly, that will rapidly block our M2 receptor on heart. So the parasympathetic activity on heart is totally lost, and sympathetic activity will lead to tachycardia and hypertension that may cause sudden death of the patient. So what is the role of atropine in OPC poisoning? By using atropine, we block the muscarinic receptor, and increased amount of acetylcholine due to organophosphorus compound poisoning cannot work on the acetylcholine receptor. So the muscarinic effects are totally lost, and we previously discussed that nicotinic effects are extremely rare. So atropine almost does all job as an antidote. The atropine should be given until atropinization. So what is atropinization? Actually, atropinization is some science by which we will understand that atropine is working properly. The most specific or most reliable sign is decrease in secretion, and the most commonly used sign is mydriasis, and the heart rate will be more than 100 beats per minute. Actually, some teachers says that mydriasis is the surest sign of atropinization. Actually, by giving atropine, pinpoint pupil can be reversed in some other condition like pontine hemorrhage, phenol poisoning, etc. If we give atropine in those conditions, their mydriasis will also be seen, but decreased secretion is the most reliable sign in case of organophosphorus compound poisoning. Then the next drug is pralidoxime. Remember, atropine is the specific antidote, but pralidoxime is not the antidote. Pralidoxime can only be given in patients whom are poisoned by organophosphorus compound within 8 hours. After 8 hours, the aging process of acetylcholine esterase enzyme is done. What is aging process? Previously, we discussed that acetylcholine esterase and the organophosphorus compound forms a covalent bond. But by the time like 8 hours, this bond becomes very strong and pralidoxime cannot break this bond. Actually, pralidoxime has affinity for this phosphorus compound, and pralidoxime breaks this bond and gets the phosphorus with him. As a result, the acetylcholine esterase enzyme is freed and reactivated. Quick recap of pralidoxime mechanism. Pralidoxime has higher affinity for phosphorus group, and it binds with phosphorus group and clip it from the acetylcholine esterase enzyme. So the acetylcholine esterase enzyme is reactivated. The dose of pralidoxime is 1 to 2 gram. Remember, it is in gram and atropine is in milligram, and given IV over 15 to 30 minutes. We should use diazepam. Diazepam is an anticonvulsant drug. It should be used if convulsion is present. The next drug we can use is sodium bicarbonate. Sodium bicarbonate can be used if there is presence of metabolic acidosis. In OPC poisoning, how metabolic acidosis is produced, we have discussed that in OPC poisoning there is bronchoconstriction. As a result, there is decrease in respiration. So there is decrease in carbon dioxide exhalation. So carbon dioxide gets accumulated in the body and carbon dioxide binds with body water and forms carbonic acid, and this carbonic acid leads to metabolic acidosis. So to reverse this metabolic acidosis, sodium bicarbonate and alkylating agent is used. And according to some new guideline, magnesium sulfate is used. Actually, what is the function of magnesium sulfate in organophosphorus poisoning? Magnesium sulfate blocks the presynaptic calcium channel. We know that there a calcium channel is present. Entry of calcium leads to secretion of acetylcholine in the synaptic cleft. So if we block this calcium channel, there is less release of acetylcholine, and as a result, less acetylcholine leads to less parasympathetic nervous system stimulation. So magnesium sulfate can be used for treatment of OPC poisoning. By blocking the calcium channel and decreasing in concentration of acetylcholine in the synaptic cleft, it improves the neuromuscular junction function, and also there is less excitation of CNS. Use of magnesium sulfate also reduces the required dose of atropine. It also reduces the mortality rate and also reduces the hospital stay. After doing this pharmacological management, we should monitor the patient for broken neck sign. Actually, broken neck sign is confirmatory of neck muscle paralysis. So, why we should know about neck muscle paralysis? Because neck muscle paralysis is the indicator of respiratory muscle paralysis. When a patient have neck muscle paralysis, it indicates that his respiratory muscle are going to be paralyzed soon, and it will be the cause of death. So we must observe the patient for broken neck sign. So that is all about organophosphorus compound. Thank you for being with me.